Good evening. Welcome to the Symposium on Spinal Muscular Atrophy. We'll be discussing about adult onset spinal muscular atrophy. These are my disclosures. So we'll be discussing whether improvement is possible. So to have an improvement in SMA for the proper treatment, we have to diagnose spinal muscular atrophy early. So if the diagnosis is delayed, and then naturally the treatment will be delayed, and so is the prognosis. Spinal muscular atrophy is a genetic neuromuscular disorder which is autosomal recessively transmitted, which results in progressive loss of anterior horn cells, resulting in hypotonia, muscle wasting, and muscle weakness. So, what is the pathophysiology of spinal muscular atrophy? So, normally, this SMN1 gene is responsible for the production of survival motor neuron protein. So the gene causes transcription and translation of the proper protein. So if the spinal muscular atrophy, if the SMN1 gene is totally absent, there is no formation of this functional SMN protein and results in breakdown of motor neurons and results in muscle atrophy. So there is a genetic backup in normal SMA patients because along with SMN1 genes, there are SMN2 genes which is responsible for the production of protein. But the problem is SMN2 gene results in 10 to 20% of normal functional proteins and 80 to 90% of the translated protein is non-functional. And hence, even if you have multiple number of SMN2 copies, they still do manifest spinal muscular atrophy. So it is transmitted as an autosomal recessive fashion. So which means that both the parents have to be carriers and there is a 25% chance that the children can be affected. But we should understand that every pregnancy, there is a 25% chance that the child can be affected. And that's why in some families, we see multiple children affected with spinal muscular atrophy. The carrier frequency is much more. So 1 in 50 people are carriers of spinal muscular atrophy, the SMN1 gene. However, they do not manifest disease in the heterozygous state. The incidence, that means in the homozygous state, the incidence is 1 in 10,000 births, and the prevalence in 1 to 2 in 100,000 individuals, which means that the survival of spinal muscular atrophy is 1 in 10 only. Now, coming to the classification, depending upon the severity and the age of onset, we divide it into type 0, 1, 2, 3, and 4. Type 0, they start manifesting in utero with reduced fetal movements and all, and the life expectancy is quite short. Type 1, they start manifesting within weeks of birth, but they do not achieve normal milestones. They are floppy babies with floppy head. They start having respiratory difficulties and untreated, they do not survive beyond 2 years. Type 2, the symptoms start after 6 months. By that time, they have achieved the sitting milestone and they're able to sit independently. But if untreated, again, they lose the milestone. They start developing respiratory difficulty and they do not survive beyond 2 years. Type 3, it usually starts after 1.5 years of age, and by that time they have achieved the milestone of walking, so they are walkers. But over time they lose the ability to walk. But because respiratory involvement is rare, the life expectancy is expected to be normal. Type 4, usually they start developing the disease after 30 years of age, and they would have achieved all milestones properly and they are expected to have a normal life expectancy. But the nature of the disease is that it is progressive and they continue to lose their motor functions over time. So adult spinal muscular atrophy is quite heterogeneous. So with the classification which you mentioned earlier, type 3 and 4 are the adult onset spinal muscular atrophy. They can be quite variable. Can be a mild one, an intermediate one, or a severe one. The severe ones, they have severe weakness. The movements can be very limited or even absent. They are the ones who have respiratory involvement, bulbar weakness. They have scoliosis, contractures of the muscles and restrictive thoracic disease. And usually they require ventilatory assistance in later life. The non-ambulatory intermediate type, they have severe arm weakness and leg weakness, but they do not have much of bulbar weakness. The respiratory compromise, although it can occur, it's not that severe. They can usually manage with BiPAP. The mild ones are the best ones which can respond to treatment. They have leg and arm involvement, but usually no facial or bulbar weakness, and they have normal respiratory function. So the symptoms and signs in SMA, in infancy, we know that they present with respiratory difficulty, failure to succumb, failure to achieve milestones. For adults, it is quite different. They start developing progressive proximal weakness in the upper limbs and lower limbs. Usually the lower limbs are more affected compared to the upper limbs. They can have muscle wasting and muscle cramps, and slowly they start losing their functional independence. So each functional score will be slowly getting lost. So difficulty climbing stairs, difficulty running initially, and then later difficulty walking, then difficulty raising the arms above the head, hand tremors, and the bulbar involvement, including tongue fasciculations, although rare, it can happen as well. Adult SMA, the other atypical feature is they can have skeletal deformities, including scoliosis, hip dislocation, joint contractures, etc. They can present with fatigue and episodic weakness, and sometimes they can have respiratory symptoms as well. If you look at the natural history of spinal muscular atrophy, they do progress. If you look at the Hammersmith functional motor scale, so every year they decline by 1.2 points, and it's a steady decline over years. Respiratory function, if you look at the deterioration, they do have a progressive deterioration, but it is not as fast as the motor function score in the upper limbs and lower limbs, and it is less compared to infants. So without treatment at any age, ambulant type 3 patients can lose the ability to walk, and over years, there can be a progressive deterioration as well. So if you look at the 6-minute walking test, you can see that over time, if you are examining, there is a progressive decline in the walking length and the walking speed. So spinal muscular atrophy in adults is often not recognized because spinal muscular atrophy is often atypical and not recognized. Understanding the clinical presentation is very important so that early genetic diagnosis can be done. So when we have to refer a patient, first of all, any patient with pure lower motor neuron syndrome, areflexia, and muscle wasting, you have to suspect a spinal muscular atrophy. You have to mention it to the patient, and always you have to ask for a genetic analysis if you are suspecting it. So spinal muscular atrophy, already discussed the clinical symptoms: increasing weakness of the legs and arms, truncal weakness, then bulbar symptoms can happen late, scoliosis, muscle contractures, and breathing problems. A lot of neurological conditions may simulate spinal muscular atrophy: spinal cord neoplasms, myopathies, juvenile ALS, congenital and hereditary neuropathies, neuromuscular junction disorders, etc. However, how to differentiate is the baseline thing is you have to look for a pure motor syndrome without any sensory involvement at all. And then you have to look for flaccid paralysis without any upper motor neuron signs at all. So any pure motor, lower motor neuron syndrome without any sensory involvement and with areflexia, that's what characterizes spinal muscular atrophy. So genetic testing of SMA, Biogen gives free genetic testing. So to detect the homozygous deletion of SMN1 gene, and it detects the number of copies of SMN2 as well for a prognostication. So it's like a dry dot test where you, with a single drop of blood, the analysis can be done. Adult patient, it's not just the motor manifestations and the physical disability that will limit their life. By the time they reach adulthood, they would have finished their family, they would have made up their career. So all those things they have to compromise once spinal muscular atrophy is detected because of the progressive motor disability. So in one of the studies which looked at the disability of spinal muscular atrophy, especially the adult onset of spinal muscular atrophy. So they have noticed that rather than physical disability, a lot of other social functioning also is affected because of spinal muscular atrophy. So it compromises the education and work environment, their relationship get affected, their family life is affected, and also it has a huge financial burden on the family. One, for the treatment. Second thing, because the patient is unable to earn because of the progressive motor disability. So knowing that it produces so much of social, physical, and psychological disability, if you ask, should adults and adolescents with SMA be treated? Of course, we have to treat them, because untreated, they do progress and they become completely dependent for activities of daily living. To have their social dignity and to have motor improvement and to have a quality of life, we have to treat them. So how can we treat, like in one of the surveys done in Europe, around 822 patients with SMA type 2 and 3 were interviewed along with their caregivers. And they found that treating them, yes, it has a positive effect on the social as well as the psychological domain for them. And also it helps maintaining the residual motor functions and promotes social integration. So what are we aiming to achieve in spinal muscular atrophy? It depends from the type of spinal muscular atrophy. When we say about adult onset of spinal muscular atrophy, it is type 2, type 3 and type 4. So type 3, if we are not treating, like natural progression is that they will have progression of disability. So if we treat early, there is a chance that almost all of the symptoms can be treated. So it achieves for a near cure or minimal manifestations. And or at least we can stabilize the disease, and already they are walkers and they become permanent walkers. They do not lose that ability to walk. So why is improvement possible in teens and adults? Let us look at the real world experience. So with treatment, what we are expecting is first to stabilize the disease and for the improvement of the motor symptoms. And if you look at the adjunctive measures like the quality of life and the biomarkers, including neurofilament light chain, and also the muscle biopsy and the respiratory functions. So all these measures, we are expecting an improvement. So if you look at the short-term targets, intermediate targets, and long-term target is to maintain or sustain the milestones achieved and to have a significant improvement in the quality of life. Short-term improvement, the first thing is to stop the progression so that they get stabilized. The intermediate thing is to have a proper therapeutic response with respect to respiratory functions and the functional outcome scores to improve. The treatment of spinal muscular atrophy, nusinersen is the first FDA-approved treatment for spinal muscular atrophy, and it has the longest safety and efficacy data. As if now we have 14,000 plus treated patients and have guaranteed efficacy and safety. So what does nusinersen do? So it's a type of gene therapy where there is the nusinersen or the oligosaccharides nucleotide is integrated to the SMN1 gene so that proper translation of stable SMN protein can happen. And nusinersen, as you know, it is injected intrathecally. The dosage schedule is a 5 ml vial, which is injected on the day 0, and then on the 14th day, 28th day, 63rd day, and then every 4 months. So in a year, the patient will be receiving 3 intrathecal injections. So because it is delivered locally, it gets directly integrated to the spinal cord anteroconsal neurons, where direct translation of the SMN protein can happen. After intrathecal administration, they achieve CSF trough concentration quite easily. So it bypasses the first pass metabolism and is delivered directly to the central nervous system where motor neurons are affected. So intrathecal delivery also decreases the off-target effects and toxicity as well. So the elimination half-life of nusinersen in the CSF is 4 to 6 months, and 0.5% of the nusinersen is recovered in urine 24 hours after intrathecal administration. Higher nusinersen doses could be more efficacious and are currently being evaluated in the DEVOTE study. No specific laboratory testing is required prior to the initiation of therapy. And nusinersen CSF exposure is constant regardless of the age and body weight. So from childhood, from adulthood, because it is administered intrathecally, the dosage is the same. Onward trials have shown that nusinersen is effective and safe for use in spinal muscular atrophy. So if you look at the real world experience of this 14,000 plus treated patients with nusinersen, almost all the studies have unequivocally and unanimously told that nusinersen is quite effective for spinal muscular atrophy. One of the largest real-world data by Hagnecker et al., which was a non-interventional multi-center observational cohort study in multiple centers in Germany, where they looked at functional outcome scores, including HF-MSC, which is the Hammersmith Functional Motor Scale Extended 6-minute walk test, and the revised upper limb module, which was done according to the recommendation of the Smart Care Real World Data Collection Initiative by trained physiotherapists. And they looked at the baseline characteristics of the patients who were evaluated at 6 months, 10 months, and 14 months. The baseline age range for initiation was from very early life to around 40 years. And the mean age at initiation was 36, 37, and 33 years respectively. Looking at the type of SMA, majority of the patients were type 3 SMA, and a small percentage of type 2 as well. If you're looking at the SMN2 copies, majority of the patients had either 3 or 4 copies, and a minority had 2 copies. The other characteristics, whether the patient has prior spondylolisthesis or not, 23% had spondylolisthesis at initiation, and looking at the ambulatory status, whether the patient was walking or not, 63% of the patients were not ambulant at initiation of nusinersen. And looking at the functional score also, they documented the functional score and looked at the improvement at 6 months, 10 months, and 14 months. And they found out that 96% of the patients improved or stabilized the motor functions. So untreated, all the patients would have declined because spinal muscular atrophy is progressive. So a stabilization of the motor functions also is an achievement, but a vast majority, 68%, had significant improvement in motor scores, which was really reassuring. And if you look at the HF-MSC at 6 months, there was a mean difference of 1.7. HF-MSC, if you look at the criteria, like it looks at the functional score with respect to each body part. So with respect to the neck movements, it is scored 0, 1, and 2. So how long is the patient able to lift up the head, and how long the patient is able to hold it up. The same for the right upper limb and left upper limb separately, right lower limb and left lower limb separately, the truncal movements, the ability to get up by themselves, ability to stand by themselves, and walking are all tested. So if the patient have an improvement of 2 scores, which means that the patient is able to do a new motor function. So, and in the study, they found that HMFSC responders more than 3 points were seen in approximately 40% of patients. Looking at the revised upper limb module, there is a significant improvement in that scale as well, because upper limb motor score is the one which gives you what is the functional independence of the patient. Even if the patient is wheelchair bound, if they have good hand function, that means they can be functionally independent because of the computer assistance. And the revised upper limb module responders more than 2 points improvement was noticed in 75% of the patients. Looking at the 6-minute walking test, there was a significant difference. And if you look at the points, as the treatment duration increases, the walking distance also will be increasing, and more than 30 meters increase was noticed in 60% of the patients. So when the patient had baseline spondylolisthesis, their improvement was a bit limited because of the bony abnormalities. And patients who were ambulant, they had a significant improvement as compared to non-ambulant ones. But if you look at the overall thing, all of the SMA patients, whether they are ambulant or not, they had significant improvement. But they found out that lower disease severity at baseline correlated with greater improvement in motor function. Safety of nusinersen, all the adverse effects noticed were procedure related and nothing with the medication per se. So the German data concluded that nusinersen is quite effective for the treatment of adult SMA and it's quite safe as well. Looking at the Polish registry, they also had more than 100 patients who were genetically diagnosed with SMA. Majority of them type 3 and some type 1 and type 2 as well. And they were treated with nusinersen. They looked at the data. The mean Hammersmith functional motor scale evaluation score at baseline was 34, ranging from 23 to 64. The mean HMFSE differences were statistically significant between baseline and each treatment time point and subsequent treatment points. So, which means that as you continue on treatment, the scores started getting improved. If you look at the HFMSE score, after 14 months of nusinersen treatment, HFMSE scores were stable or improved in 94% of the patients, rising to 96% by 30 months. And if you look at the revised upper limb module, the differences were statistically significant between baseline and each treatment time point, except that month 10, like there was a progressive improvement. During treatment, the proportion of patients who showed improvement in the upper limb function increased from 50% at month 14 to 61% at month 30. Clinically meaningful improvement in the 6 minutes walking test, that's more than 30 meters, was observed in 33% of the patient at month 6 and increasing to around 50% at month 3. So that means with 30 months treatment, at least half of the patients started having a significant improvement in the quality of walking. That's more than 30 meters of walking. During the 30 months of treatment, none of the patients reported feeling much or very much worse. So that means for sure they were all stabilized, and many of them, at least 50% of them, they had clinical improvement as well. And looking at the adverse effects, it's the same like the German data. Most of the adverse effects were related to the procedure and none to the medication per se. So they also noted that nusinersen is quite efficacious for the treatment of adult onset SMA, and it is quite safe for the treatment as well. And after 14 months of nusinersen treatment, 94% of the patients showed stable improvement. And all the motor scores, including the choke intent, HMFSE, the PGI-1 questionnaire showing the quality of life, all of them showed that there is a significant improvement with nusinersen treatment compared to not receiving treatment. Now let us look at the real world data and why improvement is possible in adults and teens living with SMA. In our hospital, we had 5 cases. Case 1, it was a 24-year-old Syrian gentleman. He had wasting of limbs since childhood, and he started having progressive weakness of limbs since past 5 to 6 years. Of late, his weakness have worsened rapidly and he's wheelchair bound. No ocular, facial or bulbar symptoms, but he has neck weakness, no sphincter disturbances, no cognitive or psychiatric issues. Due to his neurological disability, he was unable to walk or stand. He cannot even turn around in the bed without assistance, and he is dependent for activities of daily living, and he uses an electrical wheelchair. So on clinical examination, he was wheelchair bound. Higher mental functions are fine. The cranial nerve examination, there was wasting of the face, as you can see, no tongue fasciculations, and there is diffuse severe wasting of his trunk and limbs. There was generalized hypotonia, Power in the upper limb proximity was grade 3 and distally as well. In the power in the lower limbs, proximity it was grade 1 and distally grade 3. Reflexes were absent. Sensations were reduced on the left side, and the new onset sensory symptoms and rapid decline is the reason why he presented to the hospital. And he had left-sided upper limb ataxia as well. So if you look at the HMFSA score, initially it was 17 out of 66. He cannot sit up without support. He cannot stand up without assistance, and he requires assistance to turn around in the bed.
Now lift up both your hands up like this. With the right hand.
Gravity. Right side.
Lift him up as possible.
So investigations, EMG showed extensive anterior cell disease. Genetic testing diagnosed SMA3, and because SMN1 deletion was in a homozygous state, and there was 3 copies of SMN2. MRI brain and spine was done because of the sensory symptoms and the ataxia, and it showed multiple hyperintense lesions in the brain and spinal cord, and CSF-OCP was positive, and he received methylprednisolone and followed by ofatumumab, and his sensory symptoms improved. So after starting treatment for multiple sclerosis, because it took some time for the approval for insulin initiation.
Stand.
So this is the baseline. He cannot lift himself up from bed by himself.
I make up.
The walking,
But when I make like this, if I do like this,
at the pelvis, and that spontaneous movements is difficult.
stand. I make.
So
Try to lift up as much as possible.
a half kg wanted. So this is the maximum.
Okay, with the right hand.
Side to side, not against gravity. The right side was slightly.
Try to lift it up top.
Pulling himself.
Okay.
The ground. He cannot stand by himself.
Asad can hold him to stand.
And he needs to be pulled up. So 12 months treatment with nusinersen, he had almost 10 points improvement in the HF-MSE, which means that he has 5 new motor functions which he is able to do with treatment. So this is after treatment. You can see that the bulk of the muscles is much better now.
Mashallah, that's great.
And he's
Once again,
continuing with treatment.
put your hands down.
He is able to hold up the limbs for a longer
Before I
time.
put strong to down because no strong.
Power. Okay, now it is getting lift up your neck. Very good, Muhammad. That's great. Alhamdulillah.
He's able to lift his neck against gravity as well.
Try to lift. Can you move it up? Very good.
He's able to lift it up against gravity a little bit.
5, 6, 7, 8, 9, 10, 11, 12.
السلام عليكم دكتور. How are you?
In his words, he says that the muscle bulk is much better. He has gained weight of more
Before my
than
body
around
too
10
much
kg,
ضعيف.
and his muscle
I
power
speak in
is
Arabic
much
or-
better. So this is him before initiation of nusinersen. His weight was 38 kg, and with treatment in 12 months, his body weight has increased by 8 kg. And with 12 months treatment, he is able to raise the head on and turn in bed independently. Power in the upper limbs were improving and is able to carry out most activities. Power in the legs are better, but he is still dependent on activities of daily living, and he requires assistance for ambulation, but definitely his endurance is better. So why adult SMA is different? Because they have already achieved initial motor functions normally. They have normal height and weight, and they have a new onset of functional decline, impairing the quality of life. So there is a progressive decline, making them wheelchair bound and or bed bound. And with treatment, because they have achieved normal functions initially, there is a chance that with treatment they can have good improvement or near complete improvement in their motor disability. And if treatment is initiated early, the better will be the prognosis because of the better neuroplasticity. Another patient, second patient, is a 38-year-old Sudanese gentleman. He has 6 siblings, 5 are healthy, no family history. And he started having weakness quite late, after the age of 30 years. So he is SMA 4, and now he has started having deterioration of function, because of which he is wheelchair bound. He has mild scoliosis with convexity to the right. He has mild contractures of the elbow flexors and knee flexors, and severe wasting of trunk and limbs, mild neck weakness, significant lower limb weakness, and moderate upper limb weakness. Reflexes are absent. And the genetic testing was positive for homozygous deletion of exon 7 and 8 in SMN1 and 3 copies of SMN2. It took almost 5 years for the diagnosis, because initially he had walking difficulty and he was treated with vitamin tablets and all. And then we started having progressive motor weakness, and he became wheelchair bound is when he consulted a neurologist and he was diagnosed with spinal muscular atrophy. And now he is receiving the UC nursing through the patient support program. Next 3 patients are from the same family, 2 sisters, and the last one is a cousin of them. This patient is a 39-year-old Saudi lady who has progressive weakness of limbs. She is born to second-degree consanguineous parents. She has 7 siblings, out of which 5 have quadriparesis. 4 of them detected to have spinal muscular atrophy. She has progressive tremors of hands and weakness of hands and legs since 18 months of age. And until 9 years, she was walking and she became non-ambulatory afterwards. She is unable to lift arm against gravity from 30 years of age, and currently she is wheelchair bound. She doesn't have much of wasting, generalized wasting. She has wasting of the lower limbs though. Her weight is 72 kg. Her speech is normal. She has started having mild neck weakness now. The power in the upper limbs is 1/5 proximally and distally 4 minus by 5. Power in the lower limbs proximally and distally, it is 1. Reflexes were absent. She also was genetically determined SMA with homozygous deletion of exon 7 and 8. And there was 4 copies of SMN2. And it took 37 years for the diagnosis of SMA to be confirmed for her. The next patient is a sister of the previous patient. So she also have same genetic profile. She has homozygous deletion of SMN1 gene, and she has 4 copies of SMN2. And it took her 20 years for the diagnosis. Her body weight is 90 kg with a BMI of 36. She has significant weakness of limbs, and she has left equinovarus deformity as well. The last patient is a cousin of the previous patient. She also have same genetic mutation. She has SMN1 gene mutation with, and SMN2, there were 4 copies. And the clinical profile is totally different. Her weight is just 23 kg. She has severe scoliosis. She has scapular winging and wasting of limbs. She has neuropathic tremor and significant weakness of limbs as well. So it's not the genetic makeup alone which determines the phenotype. So we need to treat them early so that functional recovery can be achieved early. So functional decline in SMA is progressive. Starting treatment before significant functional impairment increases chances of near total recovery. Adult SMA has better response to treatment owing to better neuronal reserve and neuronal plasticity. Restoring motor function is equal to restoring quality of life. And we have easy access of SMA genetic testing and a patient affordability program for which we can provide easy diagnosis and early treatment for all SMA patients to have a good improvement in their quality of life. And it has established safety and efficacy data as well. Thank you.